The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. This is your host, Paul Wirkus. This week again with Kirti Sivakoti from the Primary Children's University of Utah. Are you at both places, Kirti?
Yes, that's right. Yes.
Your clinic is at?
Primary children, so there's dysautonomia clinic, pause clinic, and I split my time 50-50 between that and Gen Peds at University Pediatric Clinic.
Okay, great. Great. Last week, I think we completely plumbed the depths of POTS, and so now we understand the diagnosis and what it is completely. So before we dive in and plumb the depths of treatment, have you developed any disclosures in the last week?
No, I have not.
Okay. All right. We'll see what we can do. All right, let's talk about the current treatment of POTS. So what are we trying to accomplish when we treat POTS?
So when we treat POTS, what we're trying to accomplish, first of all, is getting patients to a baseline of being volume replete, lifestyle-wise being appropriate with their sleep as well, with everything as much as possible, optimize the lifestyle interventions, because if we're going the pharmacologic route, it's so hard to tell if medication is working if they're chronically sleep deprived or they're not eating or they're drinking 20 ounces a day. So our focus with the first line interventions, the non-pharmacologic interventions, is to get them to a baseline so we know what their body's able to do, get them into rehab, and then use medications as a bridge. It's almost like medications should help them participate better in their rehab rather than be the only rehab for them.
It seems, at least partly too, that given so much of the diagnosis is based on ability to function, giving them a little more ability to function is probably a worthy goal.
Yes, absolutely. And these patients, it's a spectrum of functioning. Some are functioning really well and some function super poorly. So I think we definitely have to cater our treatments. And as much as we want to optimize our non-pharmacologic therapies, there are some patients who have a hard time optimizing it, and that's when we lean onto our pharmacologic options a lot sooner.
Okay. So what do you recommend in terms of hydration?
Yeah. So with hydration, we are talking about 80 to 100 ounces. If it's a taller adolescent, probably higher than that, 100 to 120 ounces. And when they're drinking that amount, we are also talking about increasing your electrolytes and your sodium intake. So the goal for sodium is anywhere from 4 grams to about 8 grams. And there are different papers that talk about different goals with that. But on the higher end of the high sodium intake, it's about 8 to 10 grams of sodium. That's a crazy amount of sodium. If you look at like potassium tablets, things like that, some of them make it at 500 milligrams. So
Oh, wow.
they have to take so much of that. So we try to persuade our patients not to rely on pills, also because we don't want them to feel like they're popping pills, but we try to talk them into measurement is helpful, so we know that they're getting to the targets for at least a few weeks and then they can ease off on measurement. But an easy trick is if you take a Ziploc bag, 2 teaspoons of salt will get you to about 3 to 4 grams of sodium. If you go to about a couple tablespoons, it will get you to 8 to 10 grams of sodium. So carry that with you, put it in everything in your water, easy way to get to sodium goals.
Let me just back up a little bit. So it sounds like in a lot of ways what you're trying to do is to look at the sorts of lifestyle choices that you make as part of the solution.
That's right. So we're definitely looking at the lifestyle choices. And so it's interesting in these patients, When we ask them, are you drinking water and sodium and electrolytes? They would say, yes, I'm doing a lot. I'm getting in my snacks. But when you actually pin them down and get the numbers, it's surprisingly low. Most teenagers are not at their target. So maybe they're at 30 ounces, 40 ounces. So there's definitely room to talk about those targets and optimize it. And we do recognize that it's not going to fix POTS. If not, we would have fixed it a long time ago. But I think it's a good bridge till the other
Yeah,
rehab
yeah.
methods kick in.
It seems to me one of the biggest obstacles to that, every time I talk to anyone over the age of about 5 about drinking more in a day, is can you go to the bathroom at school?
Yeah, so that's a great point. And that's where we do accommodation. So we write letters and we encourage teachers to allow them to go to bathrooms and everything, just because we know that they're going to be peeing so much. So we work on accommodations, and our thought there is we want to accommodate, but not over accommodate our patients.
Yeah.
Yes, we want them to be peeing frequently. They have to be drinking that amount, but also we do recognize that at a certain point, we want kids to also live their life. We don't want
Sure.
teachers to be very fixated on this idea that I have to do this and that be an additional cause of stress or anxiety. So we let them pace, take it at their pace. So yeah, sometimes it's just taking baby steps to get to that goal.
Right, right. And the answer often is a little more than you're doing now.
Yes, right.
Yeah. And several tablespoons of salt is a little more than most of my patients are doing. Tell me about the exercise.
Yeah, so exercise, we really want all of our patients to get to that place. And the way we talk about it and what a lot of literature has shown is POD seems to be this response to cardiac deconditioning, whatever the cause of deconditioning be, primary, secondary, we don't know that for sure right now, but it's sort of like a physiologic response to it. So when we look at an athlete's heart rate, it's like 40s and 50s because it's so well toned and whatnot. But for the POTS heart, if there is some baseline deconditioning going on, their baseline heart rate's higher, and then they stand up, their heart rate will jump from 90 to 110. They start walking, and it's at 150. So it's almost like they're trying to jog or do something a little bit more involved than walking, and their heart's just racing at 170, 180, doesn't fill, and now they're dizzy. So what we tell our patients is the goal of exercise is to bring your physiology back into a conditioned place, so your heart rate doesn't have to be that high to get the volume out, to have that much cerebral blood flow. And in terms of exercise, there are a few different protocols that we focus on. Historically, it used to be CHOP protocol. It's very strict, I would say. It's a 20-page long protocol, and it starts with recumbent exercises, seated exercises, and then standing exercises over a month of 3, 4 months or so. The downside to CHOP protocol is that if there's somebody who can already walk 30 minutes, no problem, maybe their baseline level of functioning was they could run for 2 hours, but now they're just able to walk 30 minutes, it doesn't make sense to have them do recumbent exercises. So the second protocol that we use is called ADAPT protocol. And this protocol is more so meeting patients where their physiology is at. So we start what the patient can tolerate, and then we go from there. And what we see a lot of physical therapists do also is instead of focusing on the heart rate, they will focus on what is patient's rate of perceived exertion, and they try to stay somewhere in the middle. Don't exert too high, don't go too low, just around 5 or 6. There's a scale for that.
I think we've all seen POTS patients who, were doing a lot, say a year ago, 6 months ago, and now aren't. So is the mechanism here an accelerated deconditioning that they suddenly or fairly quickly become much more deconditioned?
Partly, yes. And I think for most patients, so the different mechanisms for this. So let's say if it's post-concussive or if it's hypermobile patients who have had a trigger, is it the fact that their autonomic nervous system is dysregulated and now they just get tachycardic very easily when they try to exercise? Is the reason why they can't keep up with the same intensity of physical activity? So that could be causing the deconditioning. But I want to say most deconditioning is probably secondary,
Okay.
not primary. Yeah.
Okay. Tell me about sleep. Is it a
Yeah.
good thing?
Sleep is an amazing thing. I wish we can all get more sleep. So Sleep, I think it's definitely a big barrier in our patient. And one of the reasons why I think behavioral health is so important, there's cognitive behavioral therapy for insomnia. So in our patients, very frequently, because of their sympathetic activation, the fight or flight mode that their bodies get into, sleep can be harder because of that, and it can also be hard because of a ton of other things. There is a paper, I think this came out of Stanford, I believe, Dr. Miglis, who worked on sleep in patients with POTS. What they noticed is they don't really have sleep apnea related issues. Sleep architecture overall seems to be okay, but what's happening is their blood pressure, heart rate tends to be higher overall at nighttime, so they don't tend to get restful sleep. They're called non-dippers. And the other thing with POTS is they seem to have their best time of the day is the evening, and they don't want to go off that morning. So really not good. They go to school, they come back, they take a nap, and now they're wide awake at night. Now they can't sleep by 9 p.m., 10 p.m. So sleep's an issue there. And then there's a thought about hypermobility contributing to sleep as well. So hypermobility and POTS is there a laxity of tissue that's causing some degree of sleep apnea that's contributing to sleep issues. So many targets.
Do you set particular sleep goals for people?
Yeah, so for sleep goals, similar to goals for everything else, whether it's for diet, for sleep, we want them, like for a teenager, 9 to 10 hours, the normal-ish, so we want them to sleep that much. But with that being said, a lot of teenagers struggle because a common pattern that we see is the fatigue so much after they come back from school, they end up taking a nap or they lay down. Now they're refreshed and they can't sleep at night. So one of the things that CBTI or behavioral health works on is how do we restructure their environment? How do we not have them lay down when they come back from school? What can we do to increase their energy levels, reduce their fatigue towards the end of the day, pace them a little bit more throughout the day so they're awake till 8, 9 p.m. and then go to bed, but normal goals as other teenagers.
What about nutrition? What do you recommend for nutritional intervention?
Yeah, so for nutrition, our goals are similar, which is we want them to be having 3 meals a day. We want them to have a balanced diet. So nutrition is tricky in our patients because when there's that autoimmune pathway, the post-infectious, whatnot, we see patients who have disorders of gut-brain interaction or maybe celiac disease or food intolerances that tests usually have a hard time picking up on what's specifically going on there. But a lot of patients have tummy-related issues, whether that's easy bloating, they can't finish their portion sizes. So nutrition is a hard thing, we feel. So we have nutritionists as a part of our program as well. And we work with families closely on number one, if they lose their feeding cues, how do we work that back? You have to have the baseline of 3 meals a day. And if you can't, can we power pack? Can you get the same amount of nutrients? Because the other risk that patients get into without meeting their nutritional goals or having malabsorptive disorders or whatnot is they're probably also mildly iron deficient. They probably have other vitamin D, other deficiencies that worsen their POTS. That contributes to their hypovolemia that worsens their POTS. So we try to optimize nutrition as much as possible, knowing that probably not all patients will get to where we want them to be. And I think that's where we lean into medication sooner or send them to GI and think about other processes.
How often do you recommend compression garments?
Always, unless there are issues, like if somebody has autism and they have sensory issues, they just can't tolerate it, something like that. We almost always recommend compression garments. And there's a paper that looked into patients with no compression garments with full length compression garments, sort of like waist high compression leggings, compared that with biker shorts, and then compared that to compression socks. And what they found is high waist compression garments that is associated with the most blunting of heart rate. The second one was biker shorts, sort of like abdominal and pelvic compression, followed by compression socks. So the thought there was, less than 20% of our blood volumes in our calves, and most of it's in our abdominal pelvic area. So if we can get them to wear high waist compression leggings, if not biker shorts, we get the most bang for our buck.
Okay. How about heat avoidance? Do you have people to avoid getting hot?
Yes, absolutely. heat is causing vasodilation, and then to prevent heat strokes, whatnot, blood, it gets redirected from that central blood volume to under our skin. So it's so easy for patients to faint because they don't have a good central blood volume
Mhm.
anyway, and now the blood's being shunted away. They faint super easy, and that seems to be one of the major triggers for POTS. So it's very hard for them to go out, walk in summer. So we talk about things like stay out during the hottest times of the day, or could you do ice cold sprays or cooling vests even? We talk to our patients about cooling
Oh,
vests.
sure.
And then hot showers seem to be really bad for our patients too. Some of our physical therapists have talked about, can you spray ice cold water on your extremities before you get out of the shower? That seems to help.
Oh, okay. So we touched on the notion of accommodations, and clearly there are some accommodations that are going to be quite helpful. What accommodations should we do? How much is enough? And can accommodations become counterproductive?
Yes, so that's a great question. You're right. They could be counterproductive. And I think there's this balance between just accommodating patients right and over accommodating them. So, in terms of accommodating, the goal is really how do we integrate them into everything that they want them to do? So, if an accommodation helps them to get to places, we definitely want to go for it. So, at school, bathroom breaks, drink more water, have snacks with you, longer time to finish assignments, allow them long breaks. So all of those accommodations are super helpful. Elevator passes, that's helpful. These accommodations we almost do universally, and then things like disability placards and things like that. We have done that on a very temporary basis, and we want to know that patients are working on physical therapy and everything else if we are doing accommodations. We definitely don't want to do accommodations like wheelchair or cane. Our goal is to move them away from it. The risk of over accommodating patients could be, I mean, let's say if somebody is in a wheelchair, it could seem like it's helping them short term, but usually whatever fitness they have left, it's easy for them to lose now because they're using wheelchair a lot more. So we want to move away from those type of accommodations.
Yeah, it's a delicate balance, isn't it, with the conditioning and the deconditioning?
Yes.
Yeah.
Yeah.
Okay, so we've tried all those things and we decide that medication would be helpful. Which medications are helpful?
Yeah, so medication, we usually use that for to improve quality of life of our patients, and we really base it on patients' physiology. And there are
Okay.
different ways that different providers use it. I should not be using the word provider, but anyway. So in terms of medication, the big categories that we look at are we have heart rate reducers. So if patients, their symptoms are predominated by just tachycardia, they stand up and their heart rate goes from, let's say, 80 to 120, they can do anything because their heart, they feel like they're going to faint, significant palpitations, then we focus more on heart rate reduction. And in that category, we lean onto beta blockers, so propranolol. We stick with low dose propranolol because that seems to affect blood pressure the least. So about like 10 to 20 milligrams propranolol. And then we have used ivabradine as well, which is not new to, it's been around. It's newer to POTS, but it's been used to reduce tachycardia and heart failure patients for a long time. But it reduces heart rate without affecting blood pressure. So these two are probably the ones that we lean on most. And then this other subtype where patients tend to pool a lot of blood, the hypermobile subtype, the ones who are low normal to lowish blood pressure, the hypovolemia type of picture presentation, we tend to lean onto mitogen. So the vasoconstriction, and what we are hoping to do is get more blood back to the heart and to the brain. And then the other medication category that we lean on is Florinef, fludrocortisone. So these are, let's say, if patients have some sort of GI issues, they just can't tolerate the crazy amounts of fluid and salt that we're asking them to drink. We would start them on Florinef. And then there are some you could add on mitogen if, let's say, you wanted more. There's still a lot of brain fog and you wanted more blood back to the heart and to the brain. If there are still persistent heart rate issues, you can try a little bit of propranolol. So there's definitely a little bit of trial and error with medication before we come to the right mix for the patient.
This is sort of an extension of what I should have asked you last week. What minimum laboratory testing would you recommend before you're comfortable saying this is POTS and not something else?
Yeah, so they should definitely have the basic workup in terms of a CBC and iron studies and ferritin levels. So there's some evidence about ferritin. If it's less than 50, POTS symptoms could be worse, 2 to 3 times worse. So looking into that, then looking into thyroid studies, chemistry. If there is pain, we would add on some of the rheumatologic labs in consultation with rheumatology. It's a little bit tricky to order, but with that being said, so inflammatory markers as well. And then with patients, if they have orthostatic symptoms, definitely getting an EKG as well. And getting a good cardiac history, depending on which we can decide if we need to refer them to cardiology or not. So, yeah.
That was a gateway to asking that there are some patients who, despite that workup, say there must be something else. Should we avoid the temptation to go down lots of alleys looking for more tests?
Absolutely, yes. We should avoid it because you're right in that this disorder is unique in that most tests come back normal. And the way messaging goes out to families, it's your tests are normal, so I don't know what's going on with you. We'll refer you here. And by the time they come to our clinic, it's almost we want answers, we want to find out what this is, maybe we need to do more. So I think also messaging it in a way that this is a software issue. Yes, there could be hardware issues as well, but there's a signaling issue here. And ActiveStan, in a way, is helpful because we can show families and we can talk about, look, there's a big increase in your heart rate. We can see this in action. So I think that's helpful. So we talk to families about trying not to go into a crazy hunt because most tests are not, we're barely seeing anything come back positive in these patients. And the longer we are stuck in this place of testing, the longer it takes for us to get in the path of functioning. So if we feel like there are some loose ends, if you're going to order some tests, we talk to families about, I think it's really going to be negative. I am just doing this to scratch off my list. If you're phrasing it that way, and talking to families about, I think it's still important that we get her back to school and have a plan for functioning and have those parallel paths. It's received a lot better.
And especially where it seems like really almost everything we're doing is designed to help improve function and
Yes.
let kids get on with their life. How much of this should be done in the primary care office and how much should be referred to cardiology, rheumatology, and neurology?
Most of this can be done at primary care office, but with that being said, there are barriers for sure. And I can talk about this from my personal experience because I
Yes.
split my time between gen peds and dysautonomia. So the tests are typically very doable in a pediatrician office. The challenge is if a teenager comes in, let's say we're seeing them for physical and we have 20 minutes, and then they talk about these symptoms. Now, having an MA go back and asking them to do a 15-minute stand test and talking about the results and ordering the test, that's a whole appointment. So I think there are barriers in that way time-wise. So thinking about what works best for practice is going to be super helpful. And I had to create this pathway for dysautonomia patients in my gen peds practice so I can spend more time with them. But I think most of it is manageable in gen peds practice. Very few patients need to go out or need to be referred out to cardiology or rheumatology or other specialties. And really, the ones who need to go out to cardiology are if there is a strong family history of some certain cardiac issues, sudden cardiac deaths, congenital heart problems, whatnot, then definitely refer them out. If you're worried about vascular EDS, now that's a tricky one. So with hypermobility, with Ehlers-Danlos syndrome, hypermobile Ehlers-Danlos syndrome, which is 90% of Ehlers-Danlos, is usually not associated with cardiac issues. So we don't have to go running into genetics or cardiology with most hypermobility. But with vascular EDS, where it goes with ruptures and with cardiac complications, we want to get that echo sooner. And we base that mostly off of family history more than our exam because these patients are actually less hypermobile than hypermobile EDS patients. So it's very hard to tell clinically. So if there's concern for vascular EDS, and then if we feel like the heart rates are crazy high, so let's say somebody is running and their heart rate's over 200, 220, we definitely want to refer them to cardiology, or they're standing and heart rate's at 180, just to rule out rhythm disorders. With regards to rheumatology, it's similar. If there's family history of rheumatologic process or joint swelling or rashes or fatigue, yes, a lot of our patients have fatigue, but in the context of other symptoms, fevers, whatnot. So I think it would be appropriate to send to rheumatology, but a lot of our patients have diffuse aches and it in rheumatology usually tries not to, it's not within there. It doesn't fit a rheumatologic diagnosis. So
Do you find that sometimes this is a new phenomenon for me that somebody's wearing a wearable monitor, the owlets for old people, the Fitbits and Apple Watches? Do you find that gives you information that you don't know what to do with sometimes?
yes. So sometimes that information tells us what we already know. We know that this patient has orthostatic symptoms, heart rate goes up, active stand tells us that. So I feel like variables usually are not very beneficial in giving us extra information. If anything, I worry about that increasing anxiety on patients' part. It's almost, oh, well, my heart rate's 150. My heart rate's 170. So it's almost, it feeds into that anxiety loop. So it's better to stay away from it, knowing that this is our diagnosis and knowing that this is the plan. And I think the downside to also having a wearable, especially let's say they're trying to recondition, is we want them to tune into their body cues and understand what is their perceived exertion, where are they going to rate it, rather than looking at a watch and feeling nervous about that. So it's better to stay away from wearables. There is role for wearables though, but I would say it's more so only the research world. So that in a larger data set over time can definitely help us identify patterns, but probably not so much day to day.
But those are data that are going to be reviewed with you that somebody can help give clarity about them as opposed to just trying to process it on your own.
That's right.
One pitch at the very end, and that's something we've talked about in various settings on the podcast already. That I think, and I'm just making a pitch here, that I think in some ways one of the advantages of treating this in the primary care office is that we can treat someone as the whole person, as opposed to defining someone by their diagnosis. The example I've used in the past is, it always makes me a little crazy when somebody says, "I'm OCD." You're not. You're a person who may have OCD. And at the same thing, I don't think that we want our patients to say, "I'm POTS," but rather, "I have POTS and this is what I'm doing about it."
That's right. So definitely being a pediatrician office, they know so much more about the patient and they can address the other components that could be feeding into the pot. So there's untreated mood disorder, there's untreated ADHD, things like that could be managed. The dynamics of what is the interaction between the parent and the child? Is there a little bit of parental anxiety that's feeding into the child? And I think as a pediatrician, we have the best relationship with our families. So I think it's such an opportunity to intervene and make changes.
So we're going to talk a little bit more about prognosis and more esoteric stuff next week. Anything else that you'd like to talk about in terms of the treatment of POTS?
The only thing I would say is right now we are moving away from some of the invasive methods, the IV fluids and things like that. So we try not to lean on that. And we talk to our families about the only reason to use IV fluids should ideally be dehydration or acute illness or something like that, but not using that on a weekly basis because there are complications and thrombophlebitis and whatnot. And also, the more they rely on some of those, that's less time spent on functioning and recovery. So there's this general shift towards non-invasive and accomplishing the same thing with less invasive stuff.
Very helpful. Dr. Sivakoti, thank you so much for, I think, helping unravel a complicated approach to a complicated diagnosis that it seems to me that this promises to give some relief to people who really struggle.
Yes, thanks for having me.
All right. We'll plan to talk again next week. For those of you out there listening, please send your questions to questions@vcurb.com. We'll talk about those in a couple of weeks. I hope there are lots of great questions. Kirti, we'll talk to you again next week.
Yes, I'm looking forward. Thank you.
Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Thanks to Phil Wirkus, who composed the theme music. See you next time.